Welcome everybody to this web lecture by a very well-established professor, Professor Francesco Blasi. Professor Francesco Blasi is a professor of respiratory medicine at the Department of Pathophysiology and Transplantation at the University of Milan. He also heads the Department of Internal Medicine and as well as the department deputy head of the cardiology unit. Most fondly, I remember him as the president of the European Respiratory Society in 2012, 2013, a time that we had much collaboration with the ERS, a time shared during my presidency of the World Allergy Organization. Professor Blasi is a well-known pulmonologist with numerous publications and is also president of many other societies. He brings to us valuable information, being actively involved in the treatment of COVID patients in his hospital with over 600 beds. And he's going to talk about COVID from the epicenter in Europe. So, Professor Blasi, please.
Okay, welcome to this lecture. I'm Professor Francesco Blasi. I work in the Department of Pathophysiology and Transplantation of the University of Milan, and I'm the head of Internal Medicine Department and the Cardiorespiratory Unit and Cystic Fibrosis Adult Center at the Fondazione Ca' Granda Milan. That is the main university hospital in Milan. And my target today is to give you some information about COVID-19 from news from the European epicenter, that is Italy, indeed. And really, we had a storm in the last 3 months here in Italy, particularly in my area in Milano. And I will show you some of the figures that we had here in Milano and in Italy, and how we deal with this real COVID storm we had. This is my disclosure, and starting to the some epidemiological data. COVID-19 clearly in less than a month become a pandemic, and you can see from this part of the graphs, Italy is the main point in Europe. We were the first country where COVID-19 started in Europe, and we are still one of the main countries in terms of number of patients, number of deaths, and so still working on this problem. One of the problems is that what we see in our country is that the elderly people are the main target of a disease. In this is not the true. If you look to, because it depends on how you test the people. If you perform a mass testing of a population, or you test only patients with clinical symptoms, you have different results. If you look to what happened in Korea, the red bars, clearly they use a mass testing, and they found that the reservoir of infection is clearly young people. If you look to what happened in Italy, where we use a testing of patients with symptoms, we found the green bars. We found that the main affected people, part of the population, is the elderly people. So clearly, it depends on how you test your population. And the same happened in this graph, comparing Iceland with the Netherlands. Iceland had the same policy as Korea, and again, the main problem is young people, where the infection is. And in the Netherlands, they use the same approach as in Italy, and they found the infection in the elderly. So young people are the main infected source, probably, and old people are the main receptors for severe infection. So it depends on how you test your population. It is quite interesting results. And when you look to what happened is clearly that almost 80% of the cases are mild cases, palsy or asymptomatic subjects. And then you have about 20% of severe cases with some something like 5% of critical cases. At the end of the day, you have people that are affected in different tissues by the infection, and clearly it depends on the presence of the receptors that are ACE2, a TMPR, SS2, and clearly the lung is the main target, but you have also liver, and indeed we record a lot of patients with liver abnormality during the infection. The nasal epithelium is clearly a good receptor for infection. The eyes are good receptors, and the heart is another target of the disease. And I will address how the disease has appeared in our population in terms of evolution. One of the points is that it's not just an epithelial disease, it's also an endothelial disease. And in fact, what happened is that in this paper is clearly stated that endothelial infection is there, and we have really an endothelitis, and this leads to alteration of the coagulation, also the peripheral coagulation. And I will show you some data about the problem of DVT and pulmonary embolism. But it's not only related to DVT, but also to peripheral involvement of the lung arteries, leading to embolism, peripheral embolism. Comorbidities are very important. Comorbidities mainly related to cardiovascular disease, but also COPD is important, and also diabetes. In Italy, we have more a higher impact of diabetes and COPD and hypertension. These are the three main risk factors and comorbidities present in our patient, and I'll show you the data. But certainly, when you look to mortality, cardiovascular disease, diabetes, and chronic respiratory disease are the main risk factor for mortality, including clearly the problem of age that I'll show you. The other problem is smoking. Is smoking a risk factor? Where the data are not consistent. We have some data from China showing that smokers are at a higher risk of having COVID-19 and to have severe symptoms, and in some way to have a higher mortality. But a recent cross-sectional study in France suggested that in COVID-19 out and inpatient, daily smokers apparently had a lower probability to develop a symptomatic infection. In Italy, we confirmed the data from China. Smokers are at a higher risk of having COVID-19. What happened in Italy? Well, we have a spread. This is a chart showing the spread by region, and clearly the region around Milano, here, Lombardia, was the most affected area in Italy. And I'll show you some interesting figure here. This is the situation at the end of February, with few cases in some restricted area, specific area in Lombardia. After 10 days, this is the situation. We have a massive spread of infection around the area of Milano, and Lombardia was deeply affected by the infection. And the mortality and the number of cases is very high. This is the area of Lombardy at May 14. We have more than 80,000 cases in our region, and compared to the rest of Italy, we have almost half of these cases was in Lombardia compared to the rest of Italy. And the number of death recoveries in blue and active cases, you can see during the different days. This is the mid of May, and this is the end of April. It's clearly the number of recoveries is increasing, the number of active cases is going down. Mortality is not changing very much. And indeed, when you look to the mortality, you can see here day by day mortality. We have a peak around the end of March with almost 900 deaths a day, and now we have around 200 deaths a day. Yesterday, we have 140 deaths. So the number of deaths is going down, but certainly is not completely away. And when you look to the case fatality rates by age, here we compare South Korea, Spain, China, and Italy. Clearly, there is no death, almost no death before the age of 30, and then the death rates increase. And what happened in Italy is that we had a very, very high lethality rate in elderly patients. That is clearly higher when compared to South Korea, Spain, and China. So the Italian elderly are at very high risk of mortality. If you are age over 70, your mortality rate may be around 15%. Why Lombardia and not the other Italian regions? Well, we have some super spreading events that deeply impacted the magnitude of the epidemic curve. Particularly, what happened is that we have two super spreading events. One is what happened in Codogno, that is a little town located in Lombardia, in the southern part of Lombardia, nearby Milano. Is about 40 kilometers from Milano. And here we had a hospital epidemic outbreak. In the emergency room arrived some patient with COVID that were not recognized as a COVID infection. And we had a spread of infection in Codogno, where now about 60% of the population has been infected. And the other super spreading event was a football match between Atalanta Bergamo and Valencia. The game was held in Milano on March 10th, and we had a really massive spread of infection in Bergamo and then also in Spain. Comparing the absolute number of deaths by age group and by gender, there is a clear impact of age, as you can see, and the men are more likely to die for this infection, apart from the more elderly patient, where clearly here the women are clearly more than the men, and so there's a difference. But clearly men are at a higher risk, and the age is one of the main points for death. What are the most common comorbidities observed in our patients? Well, ischemic heart disease is very important. We have about 1/3 with ischemic heart disease. Arrhythmia are very important. Diabetes, COPD are the main problem, and clearly this lead to the morbidity, and clearly our patient has a lot of comorbidities. You can see that about 60% of our patient has 3 or more comorbidities. So the death is clearly related to many diseases, but particularly to the number of comorbidities present in the patient. Now we are going much better. These are the cumulative total death and recoveries, and you can see that the green line is going up and the orange line is going down. That is a good thing for us. The number of deaths is going down. And this is putting together patient in ICU, patient admitted to the hospital, the red one, and the pink one are patient isolated at home. You can see we reach a peak of the intensive care around the end of March, and the same is for hospitalization. And then home isolation is going up afterward, because many of the patients that were dismissed from the hospital goes to the home isolation, and then now everything is going down. And here is quite interesting thing is the number of calls for respiratory disease to the call center in Lombardia. You can see that it corresponds perfectly on the death rate and hospital admission. The peak was around the end of the last 15 days of March, and then it's going down, and now we are about here, and clearly this is a good sign for the controlling of the infection. This is the situation in Milan. What happened is that if you compare the mortality rate between 2014 and 2019, the mortality is here, and this is the mortality this is in the first 3 months of our in Milano. The mortality rate was increased by about 63%. That is not only related to the COVID infection, but also to the fact that people are not going to the hospital, and this is related to the fear of COVID-19. So we had an increase in mortality and cardiac arrest outside the hospital related to the fear of the patient to come to the hospital, even if they have signs and symptoms of myocardial infarction. So this is clearly one of the main points we recorded in Milano. And here are what happened in our intensive care unit. In Lombardia, we are used to have about 800 beds for intensive care unit, and we more than doubled the number of intensive care in less than 15 days. And we reached the number of about 1,700 beds for intensive care unit in 15 days. And the people admitted to the intensive care have a mean age of about 60, and they were very, very compromised from the side of pulmonary function. And you can see here the PO2 VO2 ratio. That is the mean. It was 125, so very, very compromised. The VO2 and the use of PEEP in the ventilation, you can see is very high. Looking to the outcome in our intensive care units in Lombardia, it's clear that here the death rate in ICU was very high, about 26%, and this was related also to comorbidities like hypertension. The presence of hypertension is related to an increase in mortality that can reach around 40% of the patient. And clearly this is important because the comorbidities, particularly cardiac comorbidities, seems related to mortality. Let me show you what we did in my unit. We set a multidisciplinary high dependence unit in my hospital. My hospital is the main university hospital, and we always are not happy because the hospital is divided in pavilions. But in this moment, pavilions were the best way to face the disease because it's an infected disease. So we set some pavilions. This is the emergency room, and this is my ward in this area. And we had 2 floors with 41 beds for a high dependency unit. In a weekend, on Saturday and Sunday, we changed the unit, having walls everywhere, putting having a new ward, really new ward, with new pathway for the green area and the red area, so we can move around. And this is some picture of my unit, putting together the cardiology unit and the respiratory unit on the 2 floors. And this was the coronary unit before the COVID, and become a COVID unit. And you can see the patient with mask, with non-invasive ventilation, the helmet, CPAP, and this is how we are till now working in the unit. And this is how we prepare for our patients. We have a table where we put all the information, so the nurses, the physician, the physiotherapist can be updated just looking to this table about the situation of each patient. And we set a sort of procedures for the involved professional in the multidisciplinary team. We have a respiratory physician that has the initial evaluation of the patient, choose the respiratory support, evaluate and place the central venous catheter or arterial catheter, identify sign and symptom of sepsis or multi-organ failure, and decide about the therapy. Then we have the fellows. There are both cardiologists and respiratory fellows that evaluate the patient, place the arterial catheter, make any request for blood and microbiological testing, blood gas analysis, and use the lung ultrasound for following up the pneumonia. The nurses, and we set these procedures together with our nurses, they prepare the medical device, perform the electrocardiogram, place the peripheral venous catheter, bladder catheter, and so on. We are very lucky because in my unit we have 10 physiotherapists, respiratory physiotherapists that can help us in evaluation and set the ventilator and oxygen support and perform an early mobilization of our patient. And then we have the cardiologist that work together with us and with an evaluation and placement of central venous, identification of cardiac complication. Hypertension is one of the main problems, so antihypertensive therapy was set by the cardiologist, and the same for inotropic support. And then we have consultants, the infection disease specialist, the immunologist, and the intensivist. We had every day two visits of intensivist in our ward to decide, and in a multidisciplinary approach, the patient candidate to intensive care management. And this is very important to decide which patient will not go for intubation or resuscitation. This is a very difficult decision, but was very important to make it all together, intensivist, cardiologist, and respiratory physician, in order to decide the best way to manage the patient. In the peak of epidemics, we intubated the patient in the high dependency unit, and the patient remained with us for from 10 to 12 hours because we don't have enough beds in the ICU to allocate these patients, so they stay with us till the possibility to go to the ICU. We had a minimal bundle of tests at the admission, vital parameters, blood gas analysis, blood testing, including the general examination, but we also have D-dimer, ferritin, fibrinogen, pro-BNP, troponin T, and interleukin 6. This for addressing the inflammatory response of the patient and the risk of pulmonary embolism and DVT. Then we perform microbiological tests for Legionella and strep pneumonia urine antigens and blood cultures in all the patient, electrocardiogram, chest X-ray, lung ultrasounds, lower extremity venous ultrasound that was done three times a week to all the patients, an ultrasound on inferior vena cava, and the thorax CT scan was performed on clinical status and risk of superinfection or pulmonary complication like pulmonary embolism. And we perform throat cultures, rectal swab for all the patients coming from the intensive care unit, and echocardiograph. And we stratify the patient and our intervention on the basis of the level of acute respiratory failure. We use the easiest way, is the P/F ratio, and we divided the patient in 4 classes, and we use different approaches starting from low flow nasal cannula to venturi mask to high flow nasal cannula to Elmer CPAP till the the non-invasive ventilation with B-level or intubation. Then we decided how to treat the patient. The antiviral treatments, we use hydroxychloroquine in all the patients, unless there are any contraindication, particularly cardiac contraindication, and we use remdesivir. We don't anymore. We use lopinavir, ritonavir for in the first week, but we have such a number of side effects, particularly vomiting and diarrhea, that we decided to stop even before the data from China that showed that this drug doesn't seem to work in any way in a clinical setting of COVID. But we stopped the use because people on CPAP, vomiting is not the best way to treat the patient. So we decided to stop this, and stay on hydroxychloroquine, and then we have a availability of remdesivir, and we start to use remdesivir. We decided to have, after the first week, an anti-inflammatory treatment because we realized that inflammation is very, very important, and we started with anti-interleukin-1, anakinra, that is easy to use, and with a short half-life, but this is an advantage because you have an inhibition of the inflammation, but you can restore the response, the immune response in a few hours if you stop the drug. We decided to use steroids, methylprednisolone 80 milligram bolus, and then 40 milligrams twice a day. And in some cases, we use tocilizumab, but we use only in few cases because the availability of the drug was not good. And the other point is that the anti-interleukin-6 has a very long half-life, and the effect of anti-interleukin-6 can stay for more than 1 week, and this could be a problem in this kind of patient. When we use anakinra and methylprednisolone, all the patient ventilated. We use a marker with this ferritin higher than 1,000, the procalcitonin less than 1, white blood counts in between 2,000 and 10,000, no sign of sepsis, no immunosuppression. The antibiotic treatment, we try to have the lower use as possible of antibiotic treatment. We use only if the white blood count is less than 4,000 or higher than 10,000. The PCT is higher than 1, and there is some suspect of bacterial infection. We started with ceftriaxone plus azithromycin as a first choice. If Pseudomonas aeruginosa is around, we use piptazo as an alternative levofloxacin. The problem with azithromycin and levofloxacin is a possible interaction with hydroxychloroquine in terms of QT elongation. So in some cases, we can't use azithromycin or levofloxacin in this patient related to possible arrhythmia. And then we decided to have a very strong approach for antithrombotic prophylaxis and anticoagulation therapy. In most of the patients, we use 70 units per kilogram twice a day. So we moved from this, the first week, we use enoxaparin 17 units kilogram once a day, but we realized that we had a very high number of DVT and pulmonary embolism. So we decided to double the dose and go for a treatment with enoxaparin 100 units per kilo twice a day. So we use a very high level of anticoagulation therapy and prophylaxis. And this is related mainly to what we realize, and this is a clear idea that viral response phase is in the first week, more or less, and then host-inflammatory response is more important. What we are seeing is that now, after the first 3 stages, we add another stage, that is the fibrotic stage. We have a lot of patients with a fibrotic response, and also some patients with a severe emphysema following the infection. So clearly, these are problems that in the future can be important in following the patient with COVID-19. And clearly, here are some CT scan that show what happened in the lung. Just few words on some subgroup of patients. We follow cystic fibrosis because we are the referral center in Lombardia. We follow about 1,000 patients with cystic fibrosis. We don't see any problem in children. We have no children affected at all. Certainly, this is related on the fact that older age is the most affected. Symptomatic patients are elderly, and certainly CF patients are usually do not reach a very older age. But in any case, this can be protective. Certainly, our patients are used to prevent respiratory infection, and we ask them to stay at home early in the epidemic phases, we send a letter and an email to all our patients in January after the data from China, asking them to stay at home, don't come to the hospital unless there is any severe problem. And we started a telemedicine approach for following this patient. Another possible positive role was related to the use of azithromycin. About 30% of our patients are on chronic azithromycin. And certainly, there are some data showing that the lung microbiome in CF can be in some way protective for this patient. And certainly, telemedicine, what we use, is very important. Lung transplantation. We are also a center for lung transplantation. We are actually the biggest center in Italy. We follow about 180 patients with lung transplantation. And in the last 3 months, we found only 4 patients positive. And these 4 patients were hospitalized. 3 of them had a very mild disease. They were discharged after 7 days without any real great problem. Unfortunately, one of these had a very severe course with a cytomegalovirus superinfection, and she experienced an acute rejection. And even we use very high dose of steroids and try to save her. She unfortunately died after 20 days. Look into what is now published on lung transplantation. The experience is more or less the same in the different centers. Apparently, there is when infected, they had a mild moderate disease for the vast majority, and this can be related to the immunosuppressive therapy they are taking. You know, tacrolimus is a macrolide, so maybe in some way give some protection. And on the other side, the cytokine storm is probably controlled by the immunosuppressive therapy. Certainly, we have some concern about that the infection is able to trigger rejection. And just to give you this information, we just transplanted a young patient, 18 years old, after COVID-19 infection. He was absolutely healthy before the COVID-19, and the infection completely destroyed the lung. And so we decided to put him on the list. And after 1 month of ECMO treatment, we have the possibility to transplant him. And now he was intubated 2 days ago. Apparently is going well. And so with this, I thank you very much for your attention. Considering the thrombosis in COVID-19, we have some data about the 2 different possible ways for this state of hypercoagulability that is clearly present in COVID-19. From one side, we have clearly an endothelitis. So the endothelium, the destruction of endothelium leads to the presence in the blood of procoagulant factors that can induce also peripheral thrombosis. On the other side, there is a damage of the endothelium in the deep vein, and this can lead to a local thrombosis and then to embolism related to DVT. So there are different factors that can be involved. We have some data about the inactivation of complement in COVID infection. We just published a paper in Journal of Thrombosis and Research that we found that there is an activation of complement that can be one of be in part cause the problem in terms of thrombosis. And we have submitted a couple of papers, hoping that they will be published on the role of the different factors for thrombosis that are alterated and in COVID-19 infection. Considering the complement activation, I'm certainly sure that complement activation is involved in the thrombosis. And probably the activation of complement can be one target for possible treatment. Having activation inhibitors could be interesting, and we will see in the future if there is any space for this kind of approach. The difference between the severity that has been recorded in the different countries, particularly if you compare Europe to Asia, certainly this could be related to a genetic response, because apparently the main problem in the infection is not just the viral infection, but is the inflammatory response. So clearly the inflammatory response is related to the genetic, and so maybe there is a different possibility. On the other side, clearly we can't exclude that there are different strains of the virus, so having different impact in the response in terms of severity of symptoms and death. And the last one could be also how you deal with the infection. If you look to the German results, in Germany, mortality is much lower than in Italy. There are two main findings. The German people are younger. The mean age in Germany is about 7 years as a mean, less than in Italy. The other point is that the number of beds for acute and ICU in Germany are almost 3 times than in Italy, and the population is quite similar. So the approach to the admission to ICU can be another important thing, because the admission to ICU is certainly in some way can save life. So this is another important piece of a puzzle to take in account. What we see in children about the inflammatory syndrome, we have some response. In general, we have only few children affected, but in some children we have cardiovascular involvement with Takotsubo syndrome, with myocarditis. So children are less affected, but can have severe response to the virus infection. And indeed, what the difference between Europe and Italy and US in reality is related to the reporting of these cases. We have some. We don't have many, but we have some. In Milano, in this moment we have 4 children admitted to ICU for a severe myocarditis. So certainly is not a frequent event, but on the other side, certainly it may be severe. Concerning the clinical trials, we are now having some problem with clinical trials, indeed, because the number of patients is going down. But what we did is to make different studies with comparing anti-interleukin 1 with anti-interleukin 6, using different anti-interleukin 6 drugs. And recently in Milan, there is an extensive research study on the use of plasma, hyperimmune plasma, for treating severe patients admitted to ICU. And the first line reporting seems to indicate that hyperimmune plasma seems to work in terms of reducing symptoms, reducing length of stay, and probably reducing mortality. Concerning vaccines, we are really waiting for. As far as I know, there are about 50 different vaccines around the world. They are working a lot. I think we really look forward having the vaccine, because I think it's the only way to save life, and the only way to prevent the coronavirus spread again in the next years. And so clearly there is a lot of work to do, because we know very well that vaccines are not easy to select and to demonstrate the efficacy and safety, particularly. But certainly we are waiting for that. The ventilator use is a good question. We started really with CPAP, Elmer CPAP. Elmer CPAP is very Italian use of ventilation. We started with very high oxygen flow, and using high PEEP, high pressure, and the respiratory pressure. Because we think to have a pneumonia with an acute distress syndrome, and so we apply exactly the same approach. But after 1 week, we realized that the patient doesn't really improve having very high PEEP, and we decided to start to study, and we use a test that is a ZEEP PEEP test. So look into different PEEP, or going up from 0 to 15, and to find out the best approach with PEEP. At the end of the day, the result was that we need only very low PEEP. We don't need to go to 15, but we stay in between 5 and 7.5 as a PEEP, and this leads to the best results in the managing with Elmer CPAP. Considering the air pollution, well, I think the impact of air pollution has been hypothesized as a possible cause of an increase in first in infection, because there are some data showing that PM10 particulate can be a sort of taxi of the virus in the airways, and leading to an increase of infection related to pollution. So the interaction between the particulate matter and the virus. This was demonstrated in some area in Lombardia, but was not demonstrated in Milano. So I'm not sure that air pollution as it is can be really a cause of an increase of infection with this virus. Considering the lockdown and the indication to use mask, a surgical mask, and social distancing, I think that what we see here in Milan is that it works. When we locked down the city, we were really in a terrible wave of epidemic. After 2 weeks, I must say that the situation is much better. The number is going down, the death is going down, and the number of people coming to the hospital for respiratory symptoms is going down. At the end of March, we have from 60 to 100 pneumonia cases a day in our emergency room. Now we have 1, 2 every 3-4 days. So clearly the lockdown, the use of mask, the social distancing seems to work. Now we have in 2 weeks, 2 weeks ago, we opened again. So the lockdown was stopped, but the indication to use mask, gloves, and social distancing is still there. And now we really don't see any strong increase in the numbers. Hoping that is the end of the storm. We will see. We will see in the next 10 days. We will see if this works or not. The differential diagnosis in terms of mortality related to COVID and to other diseases that are coexisting with COVID is not an easy task. I must say that in the first 2 months, the indication of the government was not to perform any pathological sampling and examination. And then we started to do it, and clearly we found a lot of pulmonary embolism, a number of very severe pneumonias, myocardial ischemic diseases. So clearly the COVID is the cause of death. On the other side, comorbidities are very important, and so dissetting one from the other is not sometimes it's not so easy. But certainly, at the end of the day, probably only the pathological findings will help us to clearly distinguish between death related to COVID as it is, or related to the the worsening of the comorbidities of the patient. Concerning immunity, now we are doing a surveillance on all the healthcare professionals, and we had also just published a paper on blood donors. What we found is that apparently the virus was around since December or even earlier, because looking to blood donors results, we found that a number of people were already positive in December. So there is the virus was around, probably under the threshold of the outbreak, and then the super spreading event make this an epidemic. Certainly, what we are doing now is to have a massive searching for in all healthcare professional, all the people that are positive on antibodies are then tested for pharyngeal swabs and nasopharyngeal swabs, and certainly apparently the antibodies are inactivating the virus, so maybe protective. What we don't know is for how long this antibody stays in the body, and so we will see in the next years how the curve of antibodies will go. And on the other side, we don't know if all the patients that are seropositive are really protected. So we will see in what will happen, but certainly I think that seroepidemiology is very important to know what happened and what we can expect in the next future.